We're going to get started now. Welcome, everyone. My name is Grace Finley Golden, and I'm with Foothold Technology. Today's webinar is Value-Based Care, a primer for your agency. We have a lot of information to get through today, but we'd like to answer as many questions as possible. So if you have a question at any point during the presentation, please let our speakers know by sending a message through the chat feature on your screen. I'll now turn it over to Brianna Gilmore, Michael Blady, and David Bucciafero.
Hi, everyone. Grace, am I coming through okay?
Yep.
Okay, great. Hi, folks. Thanks for joining us. We're really pleased to be able to do this for you today. I want to thank Michael and Brianna for joining me. The three of us have worked together for a number of years on many, many different things, and this is very exciting for me to be able to be on a panel with the two of them. So I'm hoping that we can share the information that will be very useful to you around value-based payments and value-based care. If you have any questions, please feel free to ask them in the chat box, and we will try to answer them as best you can. The format we're going to use today is really I'm going to pose a few questions to our panelists, share some thoughts, and take you through what we think would be a good way of learning around what value-based care is, where it's moving in the country, and the best way for you to really move forward with value-based care. I'm just going to start off, and Michael, I'll start with you. Today,
Okay.
you know, value-based care is one of the most talked about topics along with value-based payments. I'd appreciate if maybe you could start, and then Brianna, if you could go, give us a brief definition of how you look at value-based care and what it means to you and to the organization you work with.
Okay. So let me just start off by describing a little bit about the Bridge as an agency. The Bridge is a behavioral health agency. We have about 1,300 beds of supportive housing. We have a PROS program. For those not familiar with PROS, it's kind of a continuing day treatment program, vocational program, and psychosocial program, kind of all merged together. It's particular, I think, to New York State. We have a mental health clinic. We have outpatient substance abuse services. We have 7 ACT teams. We have a health home care coordination program. We have a very close collaborative relationship with an FQHC, Ryan Health, which is co-located at our clinical hub. And so for us, value-based care really is about trying to, it's an opportunity to leverage the continuum of care of the services we have to provide our consumers with integrated, coordinated care, to come up with some novel and innovative ways of delivering that care. And it's also a challenge to us to kind of work and to start collecting the kind of data we need to understand our services, understand the efficiency and the outcomes of the services, and to make sure that we're going to be sustainable as the system moves to a value-based environment.
Thanks, Michael. Hey, Brianna, would you mind sharing some of your thoughts around value-based care and what it means to you?
Yeah, good afternoon, everyone. Thanks, David, and thank you, Michael, for that. I'll do the same as Michael did and just share a little bit about community access. We look fairly similar to the Bridge, actually. We have about 1,400 supportive housing units. That last couple hundred is kind of in the works. A little over 450 employees. We do have a PROS program, the community-based rehabilitation program, and we also have a lot of peer-run and recovery-oriented services, like our Howie the Heart Peer Specialist training program, the Blueprint Supported Education program, one of the Soft Direction pilots, Bridger program for adult homes that's rather new, as well as a Pure Run crisis respite program, as well as an advocacy department. So one of the most exciting things to me about value-based payment and really value-based care is that it's ultimately a person-centered way of structuring healthcare. And I know that's not always how we talk about it and how policymakers discuss it. And yes, there are lots of complicated analytics and financial negotiations and service reengineering and design questions that come into play. But the foundation of value-based payments is how to flexibly meet the needs of each individual member in a healthcare system. And we know that this range of needs is primarily the social determinants of health. Only about 10% of what our healthcare system now pays for is actually what goes to constituting what keeps a person healthy for the long term. So as an agency that for over 40 years has provided housing, advocacy, empowerment, and community recovery services, this has really significant implications. When the agency was first founded, when Community Access was first founded, value-based care was very obvious, right? The first tenants worked to build the first supportive housing apartments on the Lower East Side with their family members, volunteer community members, and the first employees of Community Access. And they figured out what they needed to do to live independently and stay out of the hospital. So I get really excited to know that value-based payments can actually offer the financial incentive for our agency to reorient back to the initial questions we and the tenants asked together at that time. What keeps all of us well? What keeps us happy and thriving in the community? And if anything is possible, how can we do that together? And I think that if we actually approach VDP in the right way, it's possible to ask and answer that question.
Thank you. I agree. You know, when I look at value-based care and what it means, I think back to my training at Boston University in psychiatric rehabilitation, and the approach that we always tried to take was, what is the best outcome for this individual, and what's the best way to get to that outcome in the most effective and efficient way, so that they're not participating in services that mean nothing to them, and they're not participating in the types of services that are not going to help them achieve that outcome. And I think, as Brianna said and Michael said, I think value-based care and value-based payment approaches help us get back to that focus on the individual outcomes that the individual is seeking. Could you, each of you, and Brianna, I'll start with you this time, could you describe some of the preparations that either your agency went through or you could suggest that folks go through to prepare for an implementation like value-based care? And
Yeah.
in any area you really want to focus on is fine.
Sure. I think over the next few questions, I'll kind of get to like all of those answers, because we've been through several different phases of preparation. So I want to talk about kind of what we're currently doing, because what we started doing, really there were a lot of roadblocks, and I think maybe we'll talk about that next. So currently in the phase of preparations, really led by our CEO. Our CEO has always been really oriented to trying new things that come from the voices and the needs of people with mental health concerns, first and foremost. And for the past 2 years, he and a few more of us in the agency have given a lot of thought to how design thinking, the ways that tech firms, for example, iterate on product design, can help us prepare for value-based payment contracting opportunities. It doesn't translate in every single way, but it can be very effective at getting us out of a traditional healthcare mindset. Everyone loves to think that they're innovative and open-minded, right? It doesn't matter what service system you work in. You think that you truly understand what the individuals you see every day need, that the system isn't set up to support you, and that if you could just change the way you're paid or the amount of money you get or the way services are designed, then you and your team could be more effective. I think all of us think this. But it turns out when people are given a chance to actually do that, to like ask themselves and their teams, what would you do differently from a structural perspective if you could start every day by asking a participant in front of you what they really wanted from their healthcare? It turns out that's a really challenging process. And we get really stuck in and invested in our own skill sets and methods. So we keep trying to invest in this process of design thinking. And for an agency of our size and scope, it really may be 10 years before we have a value-based payment contract that allows us this type of flexibility and system integration and risk building. But that's not a long time to succeed in shifting the culture of a workplace, even one that's already working from like a recovery-oriented, person-centered place. So I think of the work that we're doing right now is culture shifting the agency that already thinks that we're capable of like constant innovation and person-centeredness, and really getting our workforce to think of it in a different way and figuring out who's really good at thinking about things in a different way structurally. So that's where we are right now.
Thank you. Michael, some of your thoughts?
You know, I think it's interesting, Brianna, that we've also been looking at design thinking, you know, as kind of a paradigm or a way of approaching this issue. But I think I'll talk a little bit, maybe a little more concretely, in terms of we have joined an independent practice association, an IPA, because I think one of the things as an agency in terms of getting ready, a lot of what we're going to need to do in the future in a value-based environment is be part of networks that will both allow us to negotiate with managed care companies as a unit, but also that will really support integrated services, provide infrastructure support, and again, that's kind of a different paradigm, because now you're really not, you're not only functioning as an independent agency, you're also thinking of yourself as part of a larger unit that has a joint stake in how we do this work. And so it's not only just culture change within your own agency, it's also culture change among a number of agencies trying to come together. We're starting to look at how we integrate services among people who are served by more than one program within the agency. So we're looking at how we collaborate internally and using that as kind of a way of understanding how we collaborate with other agencies as well. And so we've brought on a consultant to work with us on that project, because then I think, again, one of the challenges is that it's really hard to start preparing an agency and working on going in this direction, while at the same time you're trying to provide the services on a day-to-day basis and work in the existing context. The other thing we're doing is that this is really kind of pushing us towards having a really fully electronic EHR that has all our you know, all our forms, all our data, everything in the EHR so that it's accessible, because I think data is going to be critical as we go forward, and you have to really prepare to do that, and you really have to think it through. That conversion from paper to electronic is not a simple one.
Thanks, Michael. I want to just touch upon a point that both of them made, and that's really around leadership. And as your agency prepares or is in the midst of value-based care, value-based payment transition, having leadership that is understanding of the complexity that these changes are going to mean for everyone in the organization is going to be critical. You know, really having that design thinking in place, or a real change management approach in place for your agency is going to be critical, as well as some of the other information that I think we're going to touch upon when we talk about data. But I think Brianna touched upon this, that we're going to get into with the next question, and that's that this is going to be a series of starts and go stops and redirections, because I think there are no great examples of how to what to follow to make this happen. And so I think for each of you, it's going to mean that strong leadership behind you. Because one of the next things I really wanted to ask about were the difficulties you experienced, each of you, as you prepared, whether it be a workforce readiness or regulation clarity or any other area that you may want to touch upon. And Brianna, if you wanted to start, that's fine. That'd be great.
Sure. Yeah, I think when I started at Community Access in 2015, I'd already been really thinking about value-based payment policy and kind of working in that advocacy space for a while. And so for me, I really felt very excited about the possibility to kind of approach the new regulations, kind of the yet to be set regulations, and figure out how to design the most effective value-based payment policy in New York State, alongside an agency that was really willing to look at services differently. The state had just recently announced its plan to implement VBP, and this really included pilot opportunities for small CBOs to recommend and test different approaches with managed care with the support of state policymakers. So, we excitedly gathered data and discussed with our colleagues in state government all the different ways we could meet the VBP program's goals. So, of course, we were very disappointed to learn that our data set, meaning the number of people we work with and their intersection with the acute mental health system, was too insignificant for the stage of the VBP experiment. And I think a lot of smaller agencies have gotten this message from MCOs and their policymakers in the past few years, right? You need to be seeing 5,000 plus members, you need integrated hospital and ER use tracking, you need access to primary care and prescription records, you need a lot of data sets that we don't, currently have interoperability with. So for an agency that has long provided this value-added non-medical service approach that states are looking for and thinking creatively about value-based care, it's certainly been discouraging, especially because along the way, we also joined an independent practice association, and we're trying to look at how to create larger data sets, try to figure out which of our participants are working with our partners and what data can we share, what can't we, how do we act as a fiscal service agency together. And we feel in some ways prepared for that. We feel like in some ways we've done the legwork, and still, the policy kind of isn't rising to meet our work. The places where we have been able to take on value-based contracting is actually with the city government, but it's not really value-based, it's just risk-bearing. And so this has also been, I think, a point of frustration for us as small CBOs, and I'm sure many of the participants on the phone now are kind of looking at looking at the structure of VBP contracts and being told by policymakers, like, you have to be ready to bear risk, and many of us already do, or at least receive penalties and very few rewards for some of the county-based services that we already provide. So I think that a lot of us are kind of poised. We've started and stopped. We've had some conversations. We understand part of the policy. And so, as I said before, that's really largely why we shifted internally, is because this externally focused work of reorganizing our data set, figuring out who our partners need to be, having the conversations. I think we were told to do that for so long, and it still wasn't happening, that we realized, okay, well, when the system is ready, like, we'll keep advocating, we'll keep partnering. When the system is ready, we have to be ready. So that's why we really shifted our focus internally. So yeah, we've definitely received pushback and a lot of challenges, and it's been the kind of thing that we were excited to invest a pretty big portion of executive and at least administrative and managerial time in our focus. But as Michael said, you have to daily reorient to the reality of program life. So, if you're kind of sitting on the phone thinking like, oh my gosh, we need to think about this more, you probably do. And like, we're all in this same place of, you also have to run your program and manage your program. So we get that things are like really happening slowly because of that space.
Thanks. That's a really good point. And it's interesting because, when new programs or program redesign, and you folks know my history with the PROS program, for example, and literally taking down a number of funding streams to bring that program in place. This is an entirely different world where you're still having to operate the largest portion of your company the way you've always done it, but now at the same time you are bringing in this new approach to payments and new approach to care, and it does create a lot of difficulties that are difficult, for providers to overcome. But I think you two were both giving us good examples about ways that you can do that. Michael, you mind sharing some of your thoughts around your experiences?
Yeah, I think one of the real challenges is the uncertainty of the time frames. In value-based care and payment arrangements, there are various levels of, risk and reward and the different relationships and so on that are possible. And it's really not clear what the time frame of implementation is for that. So you want to be preparing, you want to be thinking about it, you want to be on top of things, but the roadmap, how soon you have to get to that is not really clear right now. So the issue of how much time you're going to invest in it right now and what kind of changes, I think it's hard when you don't really know when this is going to happen. Certainly when you pick up the newspaper and you see, the Affordable Care Act is under siege and so on, and you think about how a lot of these arrangements and a lot of these situations are a combination of federal, state, and city initiatives. And while I think going back to what Brianna said, I think it's an opportunity, no matter how you get paid for it, to do person-centered care that improves people's lives and so on. That payment context and the organizational context is really hard to read right now. And it's hard, it makes it hard in terms of bringing it down to a line staff level around shifting that paradigm. Because you want to be talking about it, you want to get people thinking that way, you want them to be thinking about how do we improve services. Again, no matter how we're getting paid for them and how we integrate care and achieve outcomes and get better client satisfaction and so on. But, staff will look at you and say, so when's this happening? And it's very hard to tell. I think the other thing that's really been a challenge for us is the proliferation of different data sources in New York. Psyches, Medicaid data, the RIOs, we're sharing event data in hospitals, health home data systems, which are separate, and so on. There are different platforms. And so there's a ton of data that is potentially out there. And how do you integrate that? And how do you leverage it to be able to provide better care? So I think that's been an enormous challenge. And that challenge also comes with the challenge of money, because a lot of this data integration, interoperability, and so on requires investment in infrastructure, both hardware and software. And so, you know, working to see where you can get those resources. In New York, we've been fortunate that there has been a recognition that agencies do need to be able to develop that capacity. I'm not sure that's consistent across the states.
Yeah, thank you, Michael. I know, I mean, there's a couple of exciting things that are going to be happening from that perspective. The um, expansion of the EHR incentive program to behavioral health, I think it's going to help a lot of agencies be able to improve their electronic health information systems to the point where they're going to be able to pull this data, which is something we're going to talk about in a minute. But you both touched upon a piece and that I just wanted to reiterate with you. I was sharing this earlier when we were in a quiet portion, but I was at the National Council this week. I don't know who may have been on, who's on the call that was there. And I was listening in on a fireside, chat that took place with Eleanor McCants Katz, and Eleanor is the first deputy for SAMHSA. And they asked her a question about value-based care. And she said, well, my real answer is, I really don't know what it is yet, because there's been so many reiterations of what it's going to look like and how it's going to happen and what the payment model is going to be and what risk level you're going to have. And I think it just goes along with the fact that, you know, there's going to be a lot of starts and stops. It's not going to be it's not a simple transition, but it's one you can all make. And I think the tools that Michael and Brianna are giving you, I think, can help you as we go along in that. Next area I really wanted to touch upon was how the shift to how you both feel the shift to value-based payments or value-based care are going to affect your agency in the from a long-term perspective. And Michael, if you don't mind sharing your thoughts to start.
Right. I think that from, you know, a long-term perspective, we've talked about shifting paradigms of care for people. We're really going to need both to, you know, improve how we deliver care, but also to collaborate with other agencies. Brianna mentioned before the issue of size, you know, as a barrier. So one of the things that we've done is to join with community behavioral care, coordinated behavioral care, I'm sorry, in their IPA and their network of services, because that gets us up to the kind of scale that's needed to demonstrate impact on a population health level, to network and integrate services around the social determinants of health and so on. And so, and that's again also a shift for leadership, in that you're running your own agency, but now you're thinking about being part of an interdependent network where each agency has a commitment to achieving outcomes, to following, you know, to working in a certain way that benefits kind of this collaborative agency. So it's moving in some ways from not really a competitive atmosphere, but to a much more collaborative way of working that's integrated both within your agency and among other entities in your community.
Thanks, Mike. Brianna, your thoughts?
Yeah, I'm also kind of thinking future oriented, and David, in full respect of what you were just talking about is that we kind of don't know what it's going to look like. We can understand value-based payment and value-based care as a concept,
Yeah.
and yet there's sort of, I think, this like pure concept of what it could look like, or this ultimate ideal. And we know that federal policy and then state policy and then what it looks like on the ground will be like a very weird manipulation of those ideals. And so the timeline and the implications of that, like, I think we need to stay centered on the ideal and push our policymakers as far as they can really go to allow us the most amount of flexibility, and also recognize that like we're not always going to be the best poised from our seats to navigate what value-based payment becomes. And so I think that's going to look like some interesting stuff in the next few years. So really what I mean is around innovation. Like, we as community-based organizations, because of what we do every day and because of the systems that we've worked within for the past few decades, we're really not the best innovators. And I'll kind of continue to say that until the end of the webinar, and like force people to think in this way, is that with value-based payment, we're not just talking about a novel program approach. Like, we could sit around, each of us can like sit around and design a new program every day. Like, we are forced to kind of think in that mindset. But the ideal form of value-based payment would allow us to change what we mean when we say mental health program altogether. And I really see bigger systems being more capable of this at first, and then smaller agencies having far more capacity for innovation over time. I also think that we'll see a rise in the trend of boutique healthcare within the public healthcare system. So the same options that a lot of us are given in private healthcare, I think, are going to continually transition in Medicaid and Medicare. We've seen this happen a little bit, and I think that it could lead to a lot of empowerment for individuals, the applications of new technologies, ways to integrate with other community-based kind of social determinant approaches, like the things that keep our diets and our exercise, where we really want them to be, because I think that, other payers might be much better able to ask the question at this point, what do you need? And the answer can be rather authentic from an individual, rather than individuals having to access kind of the consumer landscape that's already laid out for them. So I do kind of see boutique consumer options emerging in this marketplace even more. And really in the same way, I think that we're going to see private and technology firms emerge both as partners and competitors. So a firm like Foothold that's always been a strong community partner, of course, we're working closer with our EHR technology. We're asking more of Foothold to be interoperable with the new data sets that we're getting from the state. I also think that we'll see tech firms and private companies set themselves up as competitors and potentially even new payer contractors in this environment. I think that some private firms are going to be really excited about taking on risk away from managed care organizations. And what that would look like is our Medicaid MCOs that currently get the money from the state for contract could actually step down that money to a private agency to help manage structured risk. And there's a lot of indications already within the MCOs that operate in New York that they are doing this in other states. And there's lots of tech firms that are very happy to take on financial risk and work with CBOs on tailoring innovative solutions. So on the one hand, it could siphon off administrative dollars that could otherwise be spent in healthcare, which is never a good thing. But on the other hand, it could allow us contracting opportunities with firms that are really willing to innovate and solve problems that the huge managed care companies aren't necessarily willing to solve for an agency our size. So I think that like that range of things will definitely be happening over the next 5 to 10 years, and I think new things will emerge in the next few years, especially with changes in the federal administration that we really can't foresee.
Yeah, I thank you both. As some of you may know and others may not, I sit as on the executive committee of the Electronic Health Record Association. And I can tell you that, and we are by far one of the smaller companies that sit on that. firm, but because of my experience in the behavioral health field, they really wanted us to be a part of that, because I think there's a larger recognition now of the value that behavioral health has in the healthcare realm. And I think in the future, as both Brianna and Michael touched upon, you're going to see more and more of the private sector involvement in this part of healthcare, more innovations around it. Everybody sees what Apple is doing in the app world right now, and Google, Amazon combining to create some apps in the physical healthcare world. I think you're going to see that same kind of attention being given to our sector of the world from those private companies and from various equity firms that see this. Hopefully they see this as doing good, and more healthy people is beneficial to their business rather than ways of necessarily making money. But I think people working together is going to become more and more of a value rather than an exception. We already see, for example, most of the silos that used to be in place. Michael mentioned this. There's much less of a competitive approach than there is, this is what I do really well, and I need to partner with people that do something similar, or do something that I don't do necessarily, so that we can, from a population health perspective, really move forward. So could you, each of you, sort of talk about the data piece a little bit more? For us, that's obviously, where we come into this big picture is from a data perspective. And I know at Foothold, and I know other places, there's an awful lot we're doing around preparation for value-based care. We're about to roll out, for example, a product called Insights, and that product is going to be a business intelligence program that's really going to be able to do some of the things with data that Brianna and Michael talked about. But could you each talk a little bit about how important data is to your agency moving forward? Michael, do you want to start with this one?
Sure. Well, data, I'll state the obvious, that data is really critical.
Yeah.
To one, understanding how you're doing on a population basis, and also how you're doing on, an individual treatment. How do we provide, one of the questions is, how do we provide feedback to our clinicians so that they know during the course of treatment whether what they're doing with the person, how they're working together, how does the client feel about it? How are they doing? From objective measures and also subjective measures, and how do you capture that in your data? So you want to be working with people. You want to make it actionable data. You want to know, how well are you engaging people? How well, so are they staying, which is like in our substance abuse programs is always just a huge issue, is understanding our engagement. And also, are we keeping people out of hospitals? Are the other issues that, the services that they're getting in terms of tracking their health outcomes and so on? How do you integrate all of that into knowing how well you're doing? And that's going to be when you start getting into contracting arrangements and so on. You're going to be able to need to provide that kind of data, to be able to analyze that data. Are we doing it in the most efficient and cost-effective way? As we talk again about joining into partnerships and so on, from just a sustainability perspective, whether we get a sufficient number of referrals, whether people want to work with us or not, whether managed care companies are going to want to contract with us or not, it's going to be based on data. You know, the more we move from a volume-based system to an outcomes-based system, if we don't have the data to support what we're doing, we're really going to have some serious issues. And again, integrating data from various sources.
Yeah.
So it really is critical in terms of bringing it together.
Yes. Thanks, Michael. Brianna, your thoughts?
Yeah, great. I think there's so much to say here. We've had to reorient our systems really slowly and consistently to start to answer some of the questions being newly demanded of the system. I think that a lot of us as community-based organizations, you know, especially working in New York, we might be at a really good time in this systems change to do what Michael said, was to be able to use our data, to have actionable data, because I think we went through this transition of like preparing for managed care. We started setting up kind of integrated systems. A lot of us took advantage of care coordination. We got some funds to get some new data sets. We started partnering, right? So we started building new data sets, and partly it's a demand of what the system required of us. And then I think we were all exhausted. And like for a lot of us, like we saw VBP coming, and then there was sort of a delay, and there's been weird delays in some of the managed care transitions. And I kind of think that now is a really good time to look at the data that we've collected over the past few years and to really keep asking these questions. And again, I'll like give a nod to our CEO, because I think every couple of weeks I, you know, see an email to kind of the whole executive team and saying like, I want to ask a new question. Like I want to answer these questions now. And just to say that when you are refining a data set, and for those of us who come from like a research background, you know that you start with so many more questions than you will end up wanting to keep. You need to ask yourself hundreds of questions before you figure out what's the right question that gets me the data that I can act upon. So of course we've asked ourselves questions like, you know, which of our participants are utilizing primary care? Who are their primary care doctors? Do we know them? You know, are they in our IPA? Can we share data with them? You know, can we track what happens after a person goes to the primary care doctor? And same with hospitals. You know, how often do people in our housing call 911? When do they go to the ER? What happens to them during and after a hospital stay? How does that impact the way that they use our services? And in order to really come up with the answers of those questions, and I don't think we've really gotten the answers to all of those questions, you really need to start with figuring out, and this really involved your frontline staff, like figuring out what's the best way to ask those questions. Because even if you're in an IPA structure, even if you have the most amount of partnerships, you're never going to get to a perfect data set. None of us are. Like, it doesn't matter how many more data systems we're given by the state. Like, we can have all of the data in the world to look at for our participants. We're still not going to have everything. And even if you had all of the data in the world, it's going to shift a lot of your time and attention away from participants. So we've also really tried to involve, you know, our frontline staff as well as participants themselves in figuring out, like, you know, I want to know this about you. I want to know this about your experience. What's the best way for me to find that out? How do I ask you? Because we know that our data sets are never going to give us everything that we need. And so I think the exhaustion comes from constantly asking the question and also being willing to answer it. Because of course there's times where, you know, people on the executive team will ask questions that like really are not clear and are very disruptive to the day-to-day. So I think that we need to be consistently asking new questions and have kind of a research mindset to this, and understand that if we don't know, that doesn't mean that we're doing something wrong. It just means that we like haven't involved participants in our staff in a way that's kind of research oriented and data oriented in that particular fashion. So I do understand that data collection process is exhausting and certainly takes a lot of imagination.
Yeah, thank you both. I'm just going to share a couple of thoughts myself. For those of you not in New York, New York has a regional information network approach as opposed to a single state network health information system, which basically means that there are a number of different health information exchanges of data, and each of them operate under slightly different parameters. They're each able to make up their own data set, collecting their own data set. You could be a member of one of, in fact, both of the individuals speaking today are probably members of all the health information exchanges. It doesn't mean you're going to get the same information from all of them. And it doesn't mean that they have all the information you need. I would encourage those of you who are moving towards value-based care to really get involved early in those conversations with your state or whatever organization is really coordinating this, to make sure that to the best possible way that information is available to you so that you can access that information, preferably within your EHR. If not, in that way, there's some way you can access this information and bring it into some business intelligence perspective or some type of mechanism in which you can organize and do this data. I say this from an EHR perspective, but I say this from, the two speakers that are with me here today know me very much from my days at the state government. And data is not a cheap thing. So you got to really use it, and you got to make sure you have access to that data that's important to you. And you don't want a lot of data you don't need. But as Brianna said, you're really not sure what you need at first. You're going to ask 1,000 questions, and about 20% of those are going to really result in where you're going with this. So data is going to be very important to you. The way you access it, what you can access is going to be very important to you. And I would also just add, and I'm sure Michael and Brianna would share this same thought, get involved as early as possible in the outcomes that you're going to be measured by with the data, so that you can make sure you have that information at your fingertips. Just wanted to keep moving with our questions here. Like, what steps would each of you recommend that providers take to get used to or to get ready for a value-based care system, a value-based payment approach? We touched upon a number of them, but maybe if you could each summarize sort of those thoughts that you had. Brianna, I'd start with you if you don't mind.
Sure. I'm going to get a little bit esoteric, so I'd like for you to stay with me. David laughs because that's no surprise to him. Maybe Michael can be more practical for us. So I think there's two places that we have to start, and they are opposite places. So the one place where we can access kind of the most concrete information is all of the practical and logistical questions in terms of financial planning, like data reorganization, partnering, understanding the policy. We absolutely have to start there, okay? The other step of this process, right, is an imaginary process, and we also have to start there. So I really recommend going on a personal exploration journey in your imagination. Every executive, I think, has to do this. It is a mindfulness exercise. So stay with me. So imagine for a second your most successful long-standing program. So just think about the most successful program that you run as an agency. Think of the number of staff that work within it, the size of the budget, the primary services delivered, and the ways the participants use those services. Now start to imagine what you would do if all of the actors were the same, the budget was the same, but you had absolutely none of the policy obligations or financial constraints that you currently have. Okay, so this is not an exercise in reality. This is not what value-based payment is all about, right? This is in your imagination. So if your participants left this program every day, having every single one of their healthcare needs met and listened to and attended to at the end of every day, what needs would be met that are not currently being met? not currently being met, right? So, and if your staff was capable of having any conversation, of moving about the office how they wanted to, of working the hours that participants needed them to, of working for as long as they needed to with participants, partnering with people and services in the community in an unlimited way, what would they do every day? And if you received the same gross amount of money for that program that you do now every year, so the same amount of money every year, and you could decide how to spend that money, what would you spend that money on? Okay, so I think that executives in any behavioral health organization, or really any healthcare organization in general, should spend between 5 and 60 minutes a day asking themselves these questions. I think they should really find early adopters in their agency to do this exercise along with them. That includes frontline staff, program managers, supervisors, HR staff, people at every level, to make time to do it collectively. And then after a short time, I think that you should invest in trauma-informed ways to include participants in this imagination process, and eventually shift most of your time and energy with this process into a participant-centered feedback and design process. Okay, so I think that probably most people listening are going to fall into like 3 different categories of what you think about this, right? Like some people are really excited about that. They're like, oh, I could do that. And oh, I love thinking in this way. And that's a really innovative idea, right? And then there's a third of other people who are right now thinking like, that's dumb. Like I need to know more about medical loss ratios and risk corridors and like perfecting my data set, right? And then there's like probably another third category that I think people are thinking like, oh, well, that's easy. I know exactly what I would do. I know exactly what my staff would say, and I know exactly what my participants would say. I don't need to do that for 10 minutes a day. Okay, so I think that we fall into these categories, and I would challenge you to consider that we don't know. And we have to start in both places. We have to start in this imaginary place of like, what would our system look like if our system didn't exist? And we have to start in this place of how do you build a system with the current constraints that we have. So we can do all of the work of the financial and data logistics and partnering, but if you're not doing this imaginary exercise, we're not going to get to the place that we can and need to be in terms of value-based payment. So I think that you should do this for a year. I think you should do this 10 minutes a day for a year. Involve your staff, involve participants, and then I think you should look out into the world around you and find the people and agencies that are coming up with the same answers. It might be a school on your street, it might be CVS, it might be an acute care medical system across the country. It might be a place in a different country that's come up with similar answers. I want you to do this and find out what they've done, and be very willing to listen to your participants and your staff members who are coming up with answers that you don't agree with and didn't expect. So that's my pitch for your mindfulness exercise every day.
And I'm surprised it took that long
I
for you
got
to
kicked
come up with
off.
that, Brianna, because I was expecting it earlier. Thank you. That's a great recommendation. Michael?
You're welcome.
Yeah, it's going to take me a little while to get back because I'm on kind of an imaginary plane right now. I think what Brianna just talked about really is critical for someone who's the chief operating officer of an agency. I really do think you have to take time away from your email and take time away from the press of things and ask those kinds of questions, and to think about your services in a way that isn't limited by how you're doing it now. And I do think that because the change to value-based payment and value-based care, from the payment, value-based care we should be doing. Value-based payment is a separate issue. We don't know when that's going to happen. And I think that engaging our staff now in the word value. What are our values going to be? How are we going to engage people to take charge of their lives, to, you know, see their potential in a different, you know, in different ways and so on. I really do think that's critical. I think the other thing is whether you can look at your budget and, you know, on a more practical level and pull some, you know, money aside, maybe to bring on a consultant, to have somebody who can talk with you and be a thought partner in how you make those changes. Because sometimes I think some of us who are involved in the day-to-day do get lost. And, you know, the kind of thing Brianna was just talking about is a great thing if you don't have a Brianna in-house, is to have somebody who will take you on those kinds of exercises and, you know, move you in that direction. So that's what I do. I don't think that's what I would talk about. I don't know if there are any really hard and fast things now.
No, I thank you, and Brianna, I agree fully with that. I mean, I think I know that in my own personal strive to prepare myself for change, and when I was very deeply involved in change at state government, I needed to take that step away. I remember you sharing that thought with me many times about, you know, really step away from that operational framework and really go into your mind and let yourself think of a mindful approach to this. And I think that was great advice, Michael, your advice as well. I wanted to just add one thing before we close. And that's really around the person that we're serving and the person who really is going to be affected by value-based care. And there's a lot that's happening now, I think, that can really put a person more in charge of their own health care than ever before. Access to your information, patient portals, all types of different approaches in which an individual has a greater say in what's happening to their care and greater knowledge around them knowing exactly what's happening. There's a number of initiatives that are taking place in the federal government around data blocking, where all this information should be available. There's talk now of reopening the 42 CFR, which is a piece that limits the amount of information that people have access to around substance use. There's a number of initiatives in the Opioid Support Act that are going to help with people having better access to their information, not only around opioids, but around behavioral health in its entirety. And I think the thoughtfulness that Brianna shared with us and Michael shared, your ability to just close your eyes 10 minutes a day and really think of what that system should look like, not from a perspective of what you have and how am I going to change this and change that, but what you really want it to look like, I think is important. I'd like to very much thank you both. I hope that everyone was able to get a lot out of this today. I would tell you that all of you have our email addresses through the email that we had sent you. If you don't know how to get a hold of any one of us, I know all of us would not mind an email. If you have a question, I know people tend not to want to talk on these things from a question perspective, but please feel free to reach out to us. I can't thank Brianna and Michael enough for their time. They're both very, very busy people, and I appreciate them taking this hour to spend with us. So thank you all for spending time with us. I know your schedules are difficult, and regardless of where you are in the country or in another country, we're going to make it through this. We're going to become a more successful system, I believe, from this. I think people are going to get cared for better, and I think that's what we're all about. So thank you all. Have a great day. Oh, there is a question, I believe, that we might be able to get to beforehand. And we will be offering more forums. So we'll keep you in touch with that. And Thank you, Brianna. Thank you, Michael. Thank you. It's wonderful working with you too. So be well, everyone, and we'll talk soon. Bye-bye.
Bye-bye. Thanks, David.
Thank you all.